Good morning, Dr. Siegfried.
Good morning.
Good morning, everyone. We're just waiting. We'll hope to start at 7:15 when we have a quorum. So I will be announcing that shortly. Thank you. Good morning, everyone. Thanks for joining. We're still waiting on a couple of people, board members, to form a quorum. Thank you. Hello, everyone. So we are waiting on two more DOR board members to form a quorum. And per the DOR bylaws, it says if after 15 minutes have elapsed from the start time and there is not a quorum available, then the meeting will be canceled. So let's hope they can show up pretty soon. Thanks, everyone, for your patience.
Thank you.
So just an update. It looks like at this time we only need one more board member to form a quorum. We're trying to reach out to them. All right. Thanks, everyone, for your patience. We now have a quorum, so we can go ahead and get started with our meeting. And my name is Luis Moreno, pharmacist with Utah Medicaid, and I'm just going to read reminders here. If you're dialing via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their devices, excuse me, via Google Meet. DUR board members reserve questions until the end of presentations or ask in the Google Meet chat. For those providing public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicatepharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicatepharmacy@utah.gov. Please use the chat on the right if needed, and please provide normative feedback after the meeting to help us improve our process moving forward. All right. So as part of the agenda, we first need to make a motion to approve the January DUR board meeting minutes. And so all those in favor?
Aye.
Thank you. Any opposed? Or any abstentions? All right, motion passes to approve the January DUR board minutes. And then in terms of housekeeping, we don't have any other than there are individuals that are interested in the DUR board position for consumer representative, and then also a pharmacist position that I've heard of too. And so unfortunately, I wasn't able to get the paperwork done in time to have them join and be new board members this time, but hopefully next month we'll have them participate as part of the board. In terms of the prior authorization updates, so we were able to upload into our website all the reviewed prior authorization forms from last month, from January, including the CGRP antagonist and also the botulinum toxins PAs that were updated, the novel and multimodal antidepressants PA for Auvelity, Ifetzima, Trintellix, and Vibrate, and then the Qelbree PA, as well as Suservay and Filsuvez. So just wanted to let the board know for transparency. And also another item for transparency, sorry. Also, by way of transparency, our pharmacy team here at Utah Medicaid, works hard to for the new creation of PA process to improve it, and we usually are very thorough. And the thing is that right now on the bucket that is with PAs that are ready to be presented at DUR, some of those PAs are newer and some of them were created a while back during the Change Healthcare outage. And and usually by the time they hit that bucket of they're ready to be presented at DUR, they have been vetted. We have worked on the criteria, and we have sent that criteria to our ACO partners to get their input, and so they're ready to go. But some of the PAs that are going to be presented today were created, like I said, a while back, and so it looks like one of them, slipped through the cracks, and we didn't check for updated information to see if there was any updates to the PI or any new medications that were recently approved. And so I just wanted to make that clear. And so for any of those, we'll be working on then making the necessary adjustments that we couldn't make before this meeting. So with that, we'll now move on to the portion of the agenda where we have public comment. And so The looks like we have 5 public comment attendees today. And so we'll start with Dr. Rick Kegler commenting on the medication Palynziq from BioMarin. And Dr. Kegler, are you here with us today?
Is that of the upcoming PDUFA date for Palynziq in the adolescent space? The FDA accepted the SBLA for priority review for Palynziq to expand the treatment to include adolescents aged 12 to 17. That's due anytime really up through February 28th. And then as far as Palynziq goes, just that keep in mind, majority of the patients achieve blood Phe levels of less than 360, and most achieve this Phe level with the recommended dosing schedule. The ACMG recommends patients maintain that blood Phe level below 360. This is done without the need for medical food. And really that's it, unless there are other questions. I know Palynziq has been a part of your stable of medications for a while, and I'm really just here for questions if there are anything that you guys might need.
Thank you, Dr. Kegler. We appreciate the update on the new PDUFA date for coverage for adolescents. And so, yeah, we'll make updates to the PA once that is approved.
Perfect. Thank you so much. And if you guys need any information that I can help you with, please don't hesitate to reach out. We'll make sure we let you guys know if there is an approval at or before the end of the month.
Excellent. All right, so now we'll move on to Dr. Keith Dilley from Abeona regarding Zivaskin.
Hello, thank you. So this is regarding Zivaskin. Thank you for the opportunity to speak with you today. Utah Medicaid's current prior authorization criteria for patients with recessive dystrophic epidermolysis bullosa has the requirement that members must fail both Vyjuvek and Filsuvez for at least 6 months each before Zivaskin may be considered. We believe this may create clinically inappropriate delays in access to Zivaskin, and we request the board consider whether the current step therapy requirement is clinically appropriate for all RDEB patients. I'll read out our prepared testimony and then take any questions. Let's begin with the unmet need in RDEB. This is a severe ultra-rare genetic disorder caused by mutations in COL7A1 gene, resulting in a deficiency or absence of type 7 collagen. This leads to a lack of anchoring fibrils that normally connect the epidermis to the dermis, causing extreme skin fragility and blistering. Clinically, patients present with chronic painful wounds that are slow to heal, highly susceptible to infection, and associated with squamous cell carcinoma and significant morbidity. Current management is primarily supportive, relying on time-consuming and costly bandaging routines, along with symptomatic relief and pain and itch. While a topical non-cell-based gene therapy is available, it requires ongoing reapplication, and an unmet need remains for the many patients, particularly those with extensive or chronic wounds, to achieve durable wound closure and sustained healing. Zivaskin is an autologous gene-modified cellular sheet indicated for the treatment of wounds in adult and pediatric patients with recessive dystrophic epidermolysis bullosa. These sheets are engineered to express type 7 collagen at the dermal epidermal junction and are designed for a one-time surgical application where applied. The COL7A1 transgene integrates into the host genome at the sites of application and is maintained through cell division, supporting sustained expression of type 7 collagen. In the pivotal VITAL study, patients treated with Zivaskin demonstrated clinically meaningful wound healing. 81% of wounds achieving greater than 50% healing at 6 months, compared to 16% for control wounds, which underwent the standard of care of bandaging. Among those, 65% achieved greater than 75% healing, compared to 7% for control, and 16% of wounds reached a complete closure, compared to 0% for control. In addition to wound healing, patients reported significant reductions in pain, benefits that are unique to ZevaSkin. ZevaSkin has an established safety profile. In clinical trials, most common side effects were pruritus and procedural pain. Serious allergic reactions, including anaphylaxis, may occur with ZevaSkin, and lifelong monitoring for the development of cancer is advised. No cases of squamous cell carcinoma have been reported in ZevaSkin-treated wounds, but SCC was observed in non-ZevaSkin-treated sites in 4 patients. ZevaSkin is designed to produce durable wound healing and reduce pain with a single surgical application where it's applied. As an autologous therapy, its gene-modified cellular sheets provide a personalized approach to managing wounds associated with RDEB, including large and chronic areas. And I'll yield the rest of my time and take any questions. Thank you. I realized I didn't have my camera on. Apologies.
Okay, thank you so much for sticking with their 3-minute allowed time, Dr. Daly. I appreciate it. Any questions from the board? All right, thank you so much. Next is Lauren Warren with PTC, speaking on Cephians.
Hi, everyone. Can you hear me?
Yes.
Awesome. Thanks for the opportunity to speak today. My name is Lauren. I'm a nurse practitioner and a senior medical science liaison here at PTC Therapeutics, and I support Cephians. Background, I'm sure you guys are familiar, but PKU, it is a lifelong and genetic disease requiring management of phenylalanine intake via a strict dietary protein restriction. Patients do struggle with these restrictive diets that are not only isolating and difficult to maintain, but they also lead to chronic but preventable health problems. The central goal of therapy for these patients is to safely liberalize their protein intake while maintaining phenylalanine levels within the ACMG guideline recommendations. Moving on to Cephians, it has a dual mechanism of action and utilizes an alternative pathway compared to BH4 or sapropterin. Cephians is more efficiently transported into the cells, leading to increased endogenous BH4, and it also has its own pharmacological chaperone effect on the PAH enzyme. Over 70% of patients responded to Cephians in a phase 3 clinical trial, and they saw a 63% reduction on average in their phenylalanine levels. This included patients with classical PKU, the most severe form of the disorder, and patients previously non-responsive to sapropterin. After 6 weeks of Cephians, 84% of patients achieved metabolic control and were able to enter an open label extension looking at the ability to increase their natural protein intake. 97% of patients who achieved metabolic control were able to increase their protein intake while continuing to maintain metabolic control, with 66% achieving their RDA for protein intake. I emphasize this cohort of patients did enter this dietary liberalization portion of the trial with levels in the range below 360, the ACMG guidelines. These patients experienced benefit from Cephians by maintaining metabolic control while increasing natural protein intake, showing that a policy restricting patients based on phenylalanine levels denies them from the benefit of enhanced nutritional intake. In a more recent phase 3 head-to-head trial, Cephians did demonstrate a statistically significant and meaningful superiority over sapropterin in the amount of PKU patients who were responsive to the therapy, as well as the number of patients who were able to achieve metabolic control. The study showed 70% greater reduction in blood phenylalanine levels when patients took Cephians versus sapropterin. This is an important breakthrough and reflects the very different mechanism of action that Cephians does possess. In summary, I do thank this committee for working to create a fair prior authorization criteria, really reflecting the strong efficacy and safety data Cephians possesses, making it a preferred agent and requiring no step-through or delays in treatment. I'm very happy to take questions.
Excellent. Thank you, Lauren. And yes, I believe this product, would be included for the prior authorization that we'll be reviewing today for sapropterin. And so we thank you again for informing us. I believe this medication was approved in July 2025. And
Correct.
so we hadn't gone back to look for it. But we'll definitely be considering it for inclusion into the PA criteria moving forward.
Thank you.
Thank you so much. Any questions for Lauren from the board? All right, thank you. And I see Dr. Weinstein is here.
Good morning.
Good morning, Dr. Weinstein. So right now, we have gone through 3 of our public commenters, and so now we just have 2 remaining. And so if it's okay with you, we'll continue with those public comments.
Please.
All right. Thank you. Next, we'll hear from Michael Belgoides with Neurotech, speaking on Incelto.
Oh, thank you so much, Luis. Good morning. Thank you for the opportunity to speak with you today. I'm an optometrist, biomedical scientist, and senior medical science liaison for Neurotech. Today's discussion is intended to provide scientific and clinical background on idiopathic macular telangiectasia type 2, or MACTEL for short, and to summarize publicized clinical data for Incelto, revakinagene taroretzel LUI. MACTEL is a rare bilateral progressive retinal neurodegenerative disease that leads to vision loss and visual impairment characterized by permanent loss of macular photoreceptors due to the dysfunction of Mueller glial cells, being the supportive retinal cells that produce neuroprotective factors such as ciliary neurotrophic factor, or CNTF, which is known to promote survival of photoreceptors. In the US, MACTEL has an estimated annual incidence of 8 per million people, and the mean age of diagnosis is 57 years. So MACTEL often affects individuals of working age. MACTEL negatively affects activities of daily living, social functioning, ability to work, and general mental health. One of the most reported symptoms is difficulty reading, despite having normal or mildly reduced best-corrected visual acuity, referred to as BCVA. Individuals with MACTEL also experience metamorphopsia, such as visual distortion and scotomas, which are blind spots. These cause difficulties when driving, going up and down stairs, and seeing others' faces. And until March 5th, 2025, there was no available treatment for MACTEL approved by the FDA. Incelto was a first-in-class encapsulated cell-based gene therapy approved by the US FDA for the treatment of adults with MACTEL. It is surgically implanted into the vitreous cavity during a one-time outpatient procedure and continually produces CNTF in the eye. Incelto houses retinal pigment epithelial cells, or RPE cells, that have been genetically modified to produce recombinant human CNTF with the goal of preserving retinal structure and function. Therapeutic levels of CNTF will continuously flow out while oxygen and nutrients critical for the survival of the encapsulated cells flow in. Retinal imaging is critical in the diagnosis and management of MACTEL. Spectral domain ocular coherence tomography, SDOCT, is a retinal scanning technology widely used in ophthalmology to show the layers of the retina in detail. The efficacy and safety of Incelto were evaluated in 2 identically designed randomized sham-controlled phase 3 clinical trials. The primary endpoint in these studies was the adjusted difference in rate of change over 24 months in ellipsoid zone area loss, which is a surrogate for photoreceptor viability, in the Incelto treated group compared with that in the sham group. Incelto was shown to slow the loss of photoreceptors by 55% and 31%. A reading center conducted this FDA-recognized structural measurement of easy break during the clinical trials. However, one caveat is that calculating the precise area of tissue loss is not required in everyday clinical practice to make the diagnosis. Regarding safety, Incelto was generally well tolerated. Overall, ocular treatment emergent adverse events were mild and transient, with the most serious ocular treatment emergent adverse events related to surgery were expected. Additionally, no patients had Incelto explanted during the phase 2, phase 3 clinical trials. Detailed safety information, including surgical risks and adverse event information, is described in the prescribing information. So I appreciate your time. Happy to take any questions at this point.
All right. Thank you, Dr. Belgoides. Any questions from the board? All right. Thank you so much. Next, we'll have Dr. Paul Bernstein with the Moran Eye Center speaking on Incelto.
Hello, hi, this is Dr. Bernstein. I'm a professor here at the Moran Eye Center, and I actually specialize in macular telangiectasia, or MACTEL. I've been part of the MACTEL project for about 15 years, and some of my patients were among the ones who were led to the discovery of the first genes for this condition. I see many patients with this condition. I probably have more than 200 in my practice, and Incelto is now a part of my practice. I've implanted 3 of these implants since their approval in March, and I have many more coming. This is the first treatment we have to offer these patients that are losing vision in their prime of their working years. It is designed to slow down the disease. It does not cure it, but we have seen, I was part of the clinical studies that were just discussed that led to its approval, and this is a major change in a disease that had no treatment until now. The implantation takes about an hour. It is a one-time procedure, and we are hoping for coverage with the Utah Medicaid. And I'm happy to answer any questions as someone who uses this product now and has seen that it has really changed the things that we have to offer for our patients.
Thank you so much, Dr. Bernstein. We really appreciate you being with us and sharing your expertise on this product. Any questions for Dr. Bernstein from the board at this time? Hearing none, thank you so much. And so, Dr. Weinstein, I forgot to introduce one of my colleagues, and Katie Gilliland is with us today. She is one of our amazing pharmacy technicians working with the Utah Medicaid pharmacy team, and she has graciously accepted to help us do the minutes moving forward for the DURB board meetings, and also with relaying information to our webmaster so that things can be posted on time with documents from this meeting. So thank you so much, Katie, for joining us and for accepting this responsibility.
Thank you for having me. I'm happy to be here.
Thank you
Yes,
so much.
thank you. Thank you so much.
All right, with that, I'll hand it over to Dr. Weinstein for the remainder of the meeting. Thank you so much.
Thank you very much. I apologize for my delay this morning. I'm just looking at the agenda and I'm wondering, we have one discussion before we get to Inselto. I'm wondering if we should go right to the Inselto discussion, if that's possible, given that we have Dr. Bernstein on the call and I'm sure he has patients. And I'm not sure if anybody on A would be similarly delayed with their patient care today, but maybe we can go to Inselto first on the prior auth criteria, if that would be acceptable.
Sounds great to me.
Okay, let's go to 5B and review the prior auth criteria for Inselto then.
All right. Good morning, everybody. Let me make a screen large. Okay. So I'll be presenting Inselto PA criteria in place for Dr. Iris Wan. She's not here today. So is the patient 18 years of age or older? Number 2, does the patient have a diagnosis of idiopathic macular telangiectasia type 2 MACTEL with the following criteria: inner segment, outer segment, break in ellipsoid zone between 0.16 and 2 millimeter square as measured by spectral domain optical coherence topography. That's corrected visual acuity 54 letter score or better as measured by the early treatment diabetic retinopathy study chart. Number 3, is the implant being prescribed by and administered by an ophthalmologist specializing in care patients with macular telangiectasia? Is the first eye the patient will be receiving Inselto implant, or has the patient received Inselto in a different eye and has the first eye demonstrated clinical benefit? And if the second eye, they can add the details of the first eye here. Number 5, does the provider attest that the patient does not have any of the following: active or suspected ocular or periocular infections, hypersensitivity to endothelial serum-free media, neovascular MacTel? Number 6, does the provider attest to complete all post-implant monitoring and counseling described in the current Ansaldo prescribed information, including the following: associated side effects, advising the patient to seek immediate care from ophthalmologist if they experience any signs or symptoms of an increase in fluors, the appearance of spider webs, flashing light, sensitivity to light, or loss of vision or visual field, increasing eye pain, progressive redness in the white of the eye, a sudden sensation that something is in their eye, for example, foreign body sensation or eye discharge. Evaluate implant positioning after 6 months and then annually. The initial authorization is for 1 implant per eye per lifetime. And then no reauthorization for the treated eyes. Okay. Any questions?
Actually, I do have a comment. In terms of the measurement, this is the inner segment, outer segment break. That is usually done by that was done in the study by a reading center. Typically, we as ophthalmologists in clinical practice do not have access to the software to do those exact measurements. And at least I think some people with coverage, some coverage people are not enforcing that, and there probably is benefit for lesions that are larger and smaller. This comes from the clinical studies that were published. That would be my comment. Consider not being quite so strict.
Okay, so do you recommend like removing this criteria then?
I think so. I would like the previous presenter may want to comment on that as well if he's still on. What some coverage people are saying is just having inner and outer segment break of the EZ zone, but not putting in exact numbers, because that's something that will not even be in the clinical record.
That's what I was just wondering, if those measurements aren't routinely taken in clinical practice.
They are not.
That's correct. Just to provide a little context, these measurements were performed by the Duke Reading Center with proprietary software that enabled them to measure area loss. And so utilizing, as Dr. Bernstein mentioned, OCT in clinical practice, measuring the horizontal linear area of the ellipsoid zone break provides enough diagnostic confidence to not only diagnose the disease, but also track progression.
Thank you.
So would we change that to inner segment, outer segment, ISOS, PR break in the ellipsoid zone EZ as some documentation of that linear measurement, or do we need to just take off the end of that sentence after between, after the word between, so we just know that there's a break, but we're not requiring a measurement? Because I think you would be doing whatever you have, and I'm anticipating how things go. You know, maybe eventually that software, you know, gets developed and becomes more widely available, or other methods.
I would agree. I don't think I would put a number in it. As we said, in clinical practice, we see just the horizontal. We cannot do the area. But in my practice, I would be doing implants. They would have to have an easy break before I would recommend that in patients. If they did not have that break, I would not recommend it in the patients. If they had an exceedingly large break horizontally or area, their visual acuity will be much worse than the visual acuity that you're putting in right now. So I think that it would exclude them in a different way. If they basically saying if they had an anatomically very large area, much larger than the 2 millimeter squared, they would not be seen and would not be good candidates for the implant.
Mhm. So I would take off the end of that sentence. It starts with the word between. I'm not sure if we need to put anything else there. Documented, a documented break. I mean, there's something in your notes that reflects the break.
Yeah, I mean, I would leave on by
Just take-
spectral domain OCT, that every physician implanting this would definitely have done this by spectral domain, but would document that there is a break. So I would say inner and outer segment break in ellipsoid zone documented by spectral domain optical coherence OCT.
Okay, without the numbers.
Without the numbers, yeah, exactly.
Use that to document that
Yeah.
section to
What you've
document.
highlighted right there to remove that would be better.
Thank you.
All right.
The other thing, and I don't have the numbers exactly on the next one, the ETDRS visual acuity of 54-letter score is not something that a clinical practice would do. There is a Snellen equivalent, which is what we're all more familiar with, of 2050, 2080, 2100 that you may see. And I think that I don't know the exact equivalent of 54 letters, but I'm sure Neurotech can provide that number to you.
Yes, Dr. Bernstein, thank you. That would be an approximate of 2080 Snellen acuity.
Okay. And I think that is reasonable, for people who are much worse than 2080, we would probably not be doing the implant. So I would just say 54-letter score, and
Or-
then put it, you can leave that, and you just put in what often people would do would say equivalent to a Snellen acuity of 2080.
Right. At the end of that sentence.
Yes.
Just say.
Yeah, or after
As,
better.
as equivalent to the Stellan 2080.
Yes.
Just
So like 2080, like this?
20.
Kind of a backslash.
Sorry, would you mind putting in the chat?
What we can do, we have this recorded. We can go back and listen to the recording. once we're
Okay.
done.
Thank you. It's as equivalent to Stellan 20/80.
Oh,
what
okay.
Is what we want on the end. Yeah,
Yeah.
we'll get it. Are there any other technical points with the pre-auth criteria that we need to consider?
One, Dr.
Michael,
Bernstein,
I apologize, Michael. We do have some restrictions with regards to the timing of the comments from the manufacturer.
I see. Thank you.
I think seems reasonable to me as a good start.
Thanks to you, Dr. Bernstein.
Thank you. Yeah, I think this seems reasonable.
And once these get into operation, if there are things that come up later on, they can be reviewed. I think we want to make this important therapy available. So thank you for your participation today. And I'll take a motion, unless there's any further discussion from the board, I'll take a motion to approve the pre-auth criteria as amended.
I move to approve.
Thank you. Do we have a second?
Second.
Thank you. All in favor, say aye.
Aye.
Okay, we appreciate that. Now do my agenda juggling, and let's go back to A if we can, please. And thank you to our community participants. Uh-oh, Dr. Britton.
Okay, so the next item I'll be presenting again. Okay, so we got the Javictor, Kuvan, Zelvicia, and Sulfopreptin generic. Okay, number one, does the patient have a, sorry, let me just do my, okay. So number one, does the patient have a diagnosis of hyperphenylalaninemia? Number two, is the patient diagnosis of hyperphenylalaninemia due to tetrahydrobiopterin responsive phenylketonuria? And number three, does the patient have a baseline untreated phenylalanine level of 360 micromole per liter or greater for patients up to 1 year of age, or 600 micromole per liter or greater for patients for 1 year of age or older? Number four, is a patient adherent to phenylalanine restrict diet? And then additional criteria for Kuvan: has the patient tried general sapropterin and had treatment failure or intolerance? And then they can add the details here. And reauthorization criteria: number one, has the patient had a reduction of at least 30% from baseline phenylalanine levels? Number two, if not, has the patient maintained baseline phenylalanine levels without clinically significant improvement in neuropsychiatric symptoms? Initial authorization up to 6 months, reauthorization up to 1 year. Okay, any questions about this one?
Not hearing any. There's no further discussion. We'll take a motion to approve the pre-auth criteria as written. And I appreciate Dr. Britton's indicating her vote to approve.
I'll make that motion.
Thank you. Do I have a second?
I'll second.
Thank you. Is that all in favor? Aye.
Aye.
Thank you. Next on our agenda item, I think, is to see you, Dr. Moreno, for Inspring.
Yes, that's right. So this is the PA criteria for in spring. So I'm just going through the criteria. Is a patient 18 years of age or older? Does the patient have a diagnosis of aquaporin 4 antibody positive neuromyelitis optica spectrum disorder? Is the medication being prescribed by or in consultation with the provider specializing in the condition? Has the patient experienced greater than or equal to 1 attack in the last year? Has the patient tried and failed appropriate high-dose corticosteroid therapy for NMOSD acute attack prophylaxis? Has the patient tried and failed appropriate low-dose corticosteroid therapy along with 2 or more first-line recommended immunosuppressants for NMOSD maintenance relapse prevention? Does the patient have an active hepatitis B infection? Does the patient have active or untreated inactive latent tuberculosis? Is the provider monitoring liver enzymes prior to and during treatment? Has the patient received any live or live attenuated vaccines in the 4 weeks prior to treatment initiation, or non-live vaccines in the 2 weeks prior to initiating treatment? And will the patient receive routine monitoring of AST, ALT, and neutrophil counts? And for the reauthorization criteria, has the patient had clinically significant improvement as shown by a reduction in number of relapses from baseline? And has the patient had routine monitoring of AST, ALT, and neutrophil counts? And it'll be authorized initially up to 6 months, and then the reauthorization up to 1 year. And that is all that we have for this medication. Any questions?
I think I only have one comment where we have AST and ALT abbreviated. I would probably spell those out and then put AST and ALT in parentheses behind it, just to be consistent with text in these documents.
Okay, spell them out, then have those abbreviations in
And just have
parentheses.
then just have the abbreviation follow it in parentheses. Other than that, minor edit.
Noted.
I think it's commonly understood, but
All right. Thank you, Dr. Weinstein.
thank you. If there isn't any other discussion or questions from the board, I'll take a motion to approve this pre-auth.
Motion to approve.
Thank you. Do we have a second?
I'll second.
Thank you so much. Those in favor say aye. Aye.
Aye.
And Dr. Britton's noted to approve as well. Thank you. Okay, let's see where we are. Then we have Palansic. With the presentation from Dr. Fenton.
Good morning, everyone. I'm going to be presenting the Palynziq prior authorization criteria. So I'm just going to jump right in here. So criteria for approval number 1 is the patient 16 years of age or older. This is based on the current age indication. As mentioned earlier in the meeting, there's a PDUFA date for expanding that to a younger age once that comes out. So we'll revisit that when that is official. Number 2 is, does the patient have a diagnosis of phenylketonuria? Number 3, does the patient have an untreated baseline phenylalanine level of greater or equal to 600 micromoles per liter? Number 4 is the patient's diagnosis of hyperphenylalaninemia due to tetrahydrobiopterin BH4 responsive phenylketonuria. If the patient, number 5, if the patient has hyperphenylalanemia due to BH4 responsive phenylketonuria, have they had a trial of sapropterin? Number 6, will the patient continue to maintain a phenylalanine restricted diet? And then for reauthorization criteria, has the patient had a reduction of at least 30% from baseline phenylalanine levels? And 2, if not, has the patient maintained baseline phenylalanine levels with a clinically significant improvement in neuropsychiatric symptoms? Initial authorization for 6 months and reauthorization for 1 year. And we do have like the box warnings listed in the notes, including a note to mention that mentions prescribing an auto-injectable epinephrine product due to the risk of anaphylaxis in this product. So that's the criteria. Does anyone from the board have any questions or comments?
Thank you very much for that. Can you scroll down to the bottom again where it's just that next to last bullet. So this is under a REMS program. Okay, thank you. Just want to clarify that. Anybody prescribing, including the pharmacy. Yes, Dr. Britton's asking if we could make it a little bigger. That's the Palansic REMS. Okay. Any questions or discussion from the board? If not, we'll take a motion to approve the pre-auth form. Thank you, Dr. Britton moves. Do I have a second?
Second.
Thank you. All in favor? Aye.
Aye.
Thank you very much. Okay, I think that's our agenda for today. I just have to say, having worked early in my career with pediatric neurology, just to see these advances in treatment as well as the ophthalmological advances, we are very grateful for everybody's participation and for bringing these products forward into our community here in Utah. Are there any other items, Dr. Moreno? Did we bounce anything from the very beginning of the agenda? If not,
No, I
I'll
think yes, I think we finished today's purpose. So thank you so much, everyone.
Thank you. I'll add my approval for last meeting minutes here. And as you can see, our next meeting date for March the 12th. I'll take a motion to adjourn and give you back a few minutes.
So moved.
Second.
I'll second.
Thank you. You all have a wonderful day. We'll see you next time. Thank you for your service.
Dr. Winston, I'm going to see if I can stop recording the meeting now.
Please.
All right.